Good morning, folks. Welcome to the Institute for Work and Health's speaker series. I'm delighted to be welcoming everyone to this presentation that will be delivered by my colleague, Dr. Kathleen Dobson. Just to introduce myself, my name is Arif Jetta, and I'm an Associate Scientific Director at the Institute for Work and Health and a scientist here. And I'll be moderating today's session. Before we introduce you to our speaker, Dr. Kathleen Dobson, I just want to go over some quick housekeeping notes with everyone on this Zoom call today. The first is that we are providing closed captioning, and if you do require it, you can hit the CC button on the lower right-hand side of your screen. If you run into any technical difficulties, you can contact our speaker series coordinator, Sabrina, using the Q&A function. The slides will be made available after Dr. Dobson's presentation, and you will receive a follow-up email with details on how to link to those slides. Very lastly, the speaker series is attended by many folks from across Canada and the world, and we often get a lot of questions. And we find that the best way to answer those questions is by using the Q&A function. So feel free to type those questions into the Q&A. We often cannot answer every single question that we get, and so we apologize for that in advance, and we try our best to kind of select and kind of synthesize questions so that we can maximize Dr. Dobson's time. But if we can't get to your question, feel free to contact the speaker after the presentation, and Dr. Dobson will include her contact information in her final slide. So with that, I'd like to introduce you to Dr. Kathleen Dobson. She is an associate scientist at the Institute for Work and Health and holds a PhD in epidemiology from the Dalla Lana School of Public Health at the University of Toronto. Dr. Dobson's research aims to understand how Canadians who experience mental illness and mental health challenges participate in the labor force. Her title of the presentation today is The Working Life Expectancy of Americans Experiencing Depression. And in this presentation, Dr. Dobson will discuss research on working life expectancy, that is, the number of years an individual can expect to work before permanently leaving the labor force. So with that, I'll hand it over to you, Dr. Dobson. We look forward to your presentation today.
Thank you so much, Arif, and I'd like to thank everybody for attending today. Welcome to our open speaker series. I'm delighted to be here to be talking about a study that we recently published. So for today's presentation, we'll be going over our study entitled The Working Life Expectancy of American Adults Experiencing Depression. This was recently published in Social Psychiatry and Psychiatric Epidemiology, and within the next few minutes, you should be getting a link in the chat to the article. It is free to read the entire article, so I highly suggest taking a look if you're interested after today's kind of teaser presentation. And in terms of the roadmap for today, I'll first be going over a background. So why did we decide to do this study? I will then get into the study, so talking about our study objectives, methods, and results, and then place our results or our findings in a little bit of context outside the study. So given that we're talking about depression today, I would like to get us all on the same page and start with a definition of major depressive disorder. Major depressive disorder is a mood disorder presenting as persistent low mood or loss of interest in activities that usually cause enjoyment or pleasure. These two symptoms are typically followed by other symptoms such as change in appetite, weight, sleep, feelings of guilt, or feelings of worthlessness. And unfortunately, all these symptoms manifest together as depressive episodes. So a period of 2 or more weeks when all of these symptoms are manifesting. And most individuals who experience one episode will experience another one sometime in their life course. And importantly, major depression can affect anybody at any time, and it can occur anytime across the adult life course. So given this, why is it important to focus on individuals who have depression in our labor force? First, experiencing depression is associated with an increased likelihood of unemployment. It's also associated with an increased likelihood of difficulty maintaining employment. So if somebody has depression, they may be employed for a shorter amount of time. It's also associated with early exit from the labor force. So obviously, these individual level consequences are not great for workers, and it's not great for our labor force. Secondly, depression is a highly prevalent condition, In Canada, about 5% of employed Canadians experience a depressive episode in a given year, and in America, it's about 6%. And lastly, given this high prevalence and these negative outcomes, depression is a major contributor to the indirect cost of mental illness, which in Canada has been estimated to be $6 billion per year. So given this, it's really important that we create quantitative metrics so we can have a benchmark about how our policies and interventions are helping to improve individuals with depression and other mental illness in the labor force. So we can know if these interventions or policies are working. And our study team was interested in a specific question and a specific metric. So our question was, how many years will someone who experiences depression be employed for? It's a simple question. We can talk about it in years, which is a metric that everybody understands. And fortunately for us, there's a metric that actually measures this. And you may have guessed it, it's called working life expectancy. Working life expectancy is defined as the average number of years an individual is expected to participate in employment until they permanently exit the labor force. And once we know what this metric is, we can use it as a benchmark for our policies and interventions. So are they improving the working life expectancy for individuals experiencing depression? In the demography literature where this metric is typically used, it's typically reported by gender, racial background, and education level. So when it comes to the working life expectancy among populations with depression, what do we currently know? Well, before this study, there was no working life expectancy estimate among individuals with depression in North America. And it's important to recognize that historically, Canadian data has not been available to actually answer this question, although fortunately, things are changing, so maybe in the future we'll see one for Canadians. However, when we look internationally at the literature, we see a lot of literature about working life expectancy and depression coming out of Scandinavian countries. So one study by Plana Ripoll looked at Danish civil servants with depression and compared those to those who didn't experience depression and found that the working life expectancy for those with depression was about 10 years fewer. So if you see this little stick figure chart at the bottom of our screen, after a single or recurrent depressive disorder was diagnosed, these workers were on average expected to work an additional 11 years, and compared to somebody who didn't have a diagnosis, those individuals were expected to work an additional 21 years, given that we're starting at the same starting point, so a difference of 10 years. So with the literature that we have internationally, some of the questions that still remained were, how does working life expectancy differ by depression course? Because somebody who only experiences one episode, perhaps early in their career, may look different than somebody who experiences chronic depression throughout their 20s, 30s, 40s, and 50s. Also, we didn't know how working life expectancy differed by depression course when it comes to the other sociodemographic factors I mentioned on our previous slide. So gender, racial background, and education. So given this, our study aimed to answer 3 objectives. The first was to estimate the number of depressive symptom trajectories between the late 20s and early 50s among American men and women. So this is where we can actually see the different courses of depression that this population experiences. Second, the next objective was to estimate the working life expectancy of American men and women among each depressive symptom trajectory group we found from Objective 1. And then finally, to estimate the working life expectancy for men and women among each depression symptom trajectory group, stratified by racial and education background. To complete the study, we used data from the American National Longitudinal Survey of Youth, 1979. Conducted by the US Bureau of Labor and Statistics, this was a cohort that began in 1979, and it consisted of about 12,600 Americans who were ages 14 to 21. The initial idea of this survey was to have a representative sample of Americans who were in these ages and explore their education, employment, and demographic characteristics over time. Now, this is a pretty unique survey, and I'd like to just tease apart a couple of the different parts of it that are important for our study. First, in the sampling design of the National Longitudinal Survey of Youth 1979, it actually consisted of 3 subsamples. The first subsample was a representative sample of American youth from the 50 continental states. The second subsample actually sampled Black and Hispanic individuals, as well as those who were disadvantaged non-Black or non-Hispanic, which allows us to be able to look at the working life expectancy among Black and Hispanic individuals. And lastly, the final subsample were individuals who were actively participating in the military. Now, when it came to the longitudinal design of the survey, participants were surveyed each year until 1994, and then every 2 years after. And the study is still ongoing, so we can see that it has an incredibly long follow-up time. And on top of this, every survey that somebody, one of the participants participates in, they're asked about their work history in such a way that the US Bureau of Labor and Statistics have been able to derive a work history program of weekly labor force status for each participant. So we can know if 1 week somebody is employed and the next week they're not. And that becomes very important for estimating working life expectancy, as we'll see in a few slides. For our study, the analytic sample was about 9,206 working age individuals. So they had to be between age 18 to 62 in the study. And they had to have information on their labor force status and depression measures. So now that we know a little bit about the sample, we can dive into our first objective, which is to estimate the number of depressive symptom trajectories between the late 20s to early 50s among this cohort of American men and women. To define depression, we actually define depressive symptoms based on the score from the Center for Epidemiological Studies Depression Scale short form, or CSDSF for short. For this scale, 7 questions were asked about depressive symptoms and scores ranged from 0 to 21 based on participant answers. It's important to note that validation literature suggests that a score of 8 or greater may be associated with a high likelihood of experiencing a major depressive episode. In our study, we had 4 measurements of depressive symptoms. The first occurred at the 1992 survey when participants were 28 to 35. And in our modeling, we use this as baseline time, or T0. The next measurement occurred in 1994 when participants were 30 to 37 years old, which in our modeling we called T2, time 2. The next 2 measurements occurred when participants turned 40 and then when they turned 50. So participants turned 40 between the years of 1998 to 2006. And for the purposes of our modeling, we called this time 9, or 9 years after time 0, given that that would be the mid-year between 1998 and 2006. Similarly, when participants turned 50, we called this time 19 in our modeling. The analytic technique that we used was latent growth mixture modeling, which would allow us to see what these trajectories look like over time, as well as quantify the number of trajectories of depressive symptoms that existed in our sample. When we did that, we found that there were 5 latent trajectories of depressive symptoms within the sample. So I'll be walking us through this graph where we can see our x-axis, or horizontal axis at the bottom, shows time. The vertical axis, or the y-axis, shows the average CSDSF score. And then we have our 5 different depression trajectories in different colors. So the first trajectory that I'd like to talk about is what we call the low persistent symptom trajectory. This comprised about 75% of the sample, and as you can see, they had average CSDSF scores of about 3 to 2 over the entire period. So for all intents and purposes, this group had a low likelihood of experiencing a depressive episode. Our next 3 trajectories, which comprised about 22% of the sample, had some sort of episodic depressive symptom course. So at one time point, these individuals had a score of greater than 8. So for our red line, we can see that these individuals had a score of about 10, which decreased over time before age 40. The light blue line had their high symptom around age 40, and the yellow line had their high symptom around age 50. Our final trajectory, which we called our persistent symptom trajectory, had average scores of about 13 across the entire period. So again, why we called them the persistent high trajectory group. So now that we had answered objective 1, we then moved to our second objective, to estimate the working life expectancy of American men and women among each of these depressive symptom trajectory groups. For this objective, the measure that we used in our modeling was monthly labor force status measurements between ages 30 to 62. And I'll show you in a second on our next slide what our labor force states were. Once we had our measure all ready to go, we then stratified our sample by depression symptom trajectory and gender. So given that we had 5 symptom trajectories and 2 genders, we then had 10 individual groups. Among each of those groups, we computed a 5-state continuous time non-homogeneous Markov multi-state model to be able to see how individuals transitioned between different labor force states over their 20 to 30-year follow-up. Then to be able to answer our question, or our objective, from the model, we then used simulation techniques to estimate working life expectancy in 5-year increments between the ages of 30 to 60. And the definition of working life expectancy we used in our study was the expected number of years a person would remain employed at a specific age, conditional that they were employed at that specific age. So this is what our multi-state model looked like, the figure on the left-hand side of your screen. You can see that we have 5 states. We have employed, unemployed, out of the labor force, and suboptimal labor force participation. This last group was a combination of being a little unclear about if somebody was truly employed or unemployed, as well as individuals who had a health status impacting their ability to work. We can also see from this figure that individuals could transition between each of these states freely. So you could go from employed to unemployed to back to employed. Our final state was death, which, as you can see, is kind of a one-way ticket because once you're dead, unfortunately, you can't come back to work. So based on our data, we had over 2.7 million monthly labor force states in our sample, and I've broken it down in the table on the right by the overall sample, men and women. Most participants, or the highest proportion of labor force states, fell in employed, followed by out of the labor force, unemployed, suboptimal labor force participation, and we had 818 participants die over the follow-up. So these graphs show the estimates of working life expectancy by age, gender, and depressive symptom trajectory that we were able to acquire from the model that I just showed on the previous page. So we have the working life expectancies for men on the left, women on the right. Our x-axis again is age, and our working life expectancy estimate is our y-axis. Each of the different color lines represents one of the different depression symptom trajectories. So the first thing you'll notice is that for all trajectories and for men and women, as age increases, working life expectancy estimates were expected to decrease. And this makes sense. It was something that we were expecting because as you age, we all hope for a nice retirement. So the older you are, the less likely that you are to remain employed. Now, I'm going to walk through what we saw for the different working life expectancy estimates for our different depression trajectories. So this top dark blue line represents the persistent low symptom trajectory group. And we can see that the estimate is similar at age 30 for men and women. And the way that we interpreted this was at age 30, if an individual in this trajectory group was employed, their working life expectancy estimate was approximately 30 years. So in other words, if somebody was employed at age 30, they were expected to work an additional 30 years, so bringing them up to work until age 60, which this estimate makes sense. For our 3 episodic groups, we could see that the working life expectancy at age 30 was lower and remained lower pretty much throughout the entire age period we looked at. So in defining these at age 30, if an individual in one of these trajectories was employed, on average, they were expected to work an additional 20 years if they had their episode around age 40 or 50, or about 23 to 25 years if they had their episode before the age of 40. So these individuals were expected to work until age 50 or 55, so 5 to 10 years lower than those who had low depressive symptoms. Our final group in the green line are the individuals who had persistent high depressive symptoms. And when we interpret this at age 30, on average, if somebody in the persistently depressed or high symptom group was employed, their working life expectancy was about 13 to 14 additional years. So said another way, on average, if these individuals in the persistent high symptom depression trajectory were employed, they were expected to work until age 43. So again, we can see that there is a clear gradient depending on the severity of depression and working life expectancy. So now that we have our depression symptom trajectories, we've estimated overall working life expectancy for men and women in each of the trajectory groups. We wanted to take this one step further, and for our third objective, we estimated working life expectancy for men and women among each of these trajectories for different racial and education backgrounds. So to do so, we followed a very similar design, except the difference here is that we ran our multi-level models that included racial background as a covariate, and then simulated working life expectancy for each subgroup among each depression trajectory and gender. And by subgroup, I mean each different racial category, which was Black, Hispanic, or non-Black, non-Hispanic, and the latter group contained about 85% of Caucasian individuals. And then after we had completed our models for racial background, we repeated the same process for educational background. So in our multi-state models, we included education as a covariate, and then in our simulations, we estimated the working life expectancy for each different education level and each different depression symptom trajectory for men and women. And before I show you what those results are, I think it's important to have a little bit of understanding about what the demographic factors looked like for each of our trajectories. So don't worry too much about the numbers in these tables. I'm going to walk us through, but essentially what it shows is the distribution of our different genders, race, ethnicity, and education levels in our overall sample, and then by each of our depression symptom trajectories. So when it comes to gender, we can see that in the low depressive symptom trajectory, about 53% of the sample was male, and we compare this to the high persistent symptom trajectory group, where primarily the majority of individuals in this group were female. And this is something that we would expect given the epidemiology of depression, and that we know the prevalence is typically higher among women compared to men. When we then see by race ethnicity, and I've also included the gender and race ethnicity breakdown, we can see among the low depressive symptom group, about 52% of the sample are non-Black, non-Hispanic, which decreases in our other samples. For our three episodic trajectories, we see that between a third to a fourth of participants are Black. And I just have to move that to the other side so I can see for the persistent depressive symptom group, about 33% of this group were Black, 26% were Hispanic, and 42% were non-Black, non-Hispanic. And then lastly, for highest level of education, we can see that the majority of participants in each of these different trajectories had a high school diploma. However, when it came to having a college degree or the highest level of education at age 30, 21% did in the low depressive symptom trajectory group, compared to 9 or 8% in our episodic trajectory groups, and then 4% in our persistent depression high symptom group. So clearly we're seeing an educational gradient here. Now, when it came to working life expectancy, when we broke it down by racial background, for men, we saw a trend that Black men among all depressive symptom trajectory groups reported lower working life expectancy compared to non-Black, non-Hispanic men. When it came for women, we saw that Hispanic and Black women in the episodic at age 50 and persistent high symptom trajectory groups had working life expectancy estimates about 4 to 6 years lower at age 30 compared to women who were not Black or not Hispanic. And when we looked at education, again, we saw this educational gradient in working life expectancy at age 30 among all trajectory groups. So again, the educational disparities that we were seeing in our descriptive statistics still remained in our working life expectancy estimates. So those who were in the highly persistent depressed group who did not have a high school education had the lowest working life expectancy compared to those who had a high school education or a college education, but these were still lower compared to the other depression symptom trajectory groups. So up until this point, I've shown you some numbers, I've shown you some graphs, and I've said depression symptom trajectory group probably about 50 times. So I'd like to summarize what our findings are, talk about the limitations of the study, and how we can actually use this evidence to potentially inform practice in the future. So from our findings, the key takeaways are this. First, for our first objective, we saw that about 25% or a quarter of Americans experienced high level of depression symptoms at least once during their prime working years. From our second objective, we saw for both men and women, experiencing even episodic depression impacted their working life expectancy. We also saw a little bit of a difference depending on, for the episodic trajectories, when the high depressive symptoms occurred. So for those who had their episode in later life at age 40 or 50, this potentially was because these individuals had been in the labor force long enough that they had options for early retirement or pension payouts, which made it possible for them to actually leave the labor force earlier. However, for individuals who have their episodes of high depression in early life, this may be due to difficulty maintaining employment and job turnover. So again, this may be why this group has a lower initial working life expectancy compared to individuals who don't experience depression. And lastly, from our third objective, we saw that disparities in working life expectancy grew among racialized Americans, as well as Americans with lower levels of education. And we saw this across all depression symptom trajectories. So this study gives us a lot of information, but it's not a perfect study, and I think it's really important to talk about what its limitations are. First, when it comes to measurement, our CSDSF, so how we measure depression symptoms, is not a clinical instrument. So we can't say with 100% certainty that these individuals actually had a depressive episode or they didn't. We can just say this is what their symptom score is, and based on this, it's quite likely that they experienced a depressive episode. If there's bias coming out of our measurement, it's likely that we've actually underestimated the proportion of individuals who are experiencing depressive episodes. Secondly, when it comes to our third objective specifically, some of our different subgroups, so when we broke it down by gender, depression symptom trajectory group, and then our different races and our different education levels, some of our subgroups had quite small sample sizes, making it difficult to confidently say that these are the true working life expectancy estimates. Before we can do that, we definitely need additional research with greater sample sizes. And lastly, when it comes to potential analytic bias in these studies, there's numerous assumptions that we had to make in our multi-state models, and the authorship team tried to be quite thoughtful with it. But if there are assumptions that are incorrect here, it might bias the findings that we have found. But despite those limitations, we were still able to answer our initial question. How many years will someone who experiences depression be employed for? Well, based on our study, we saw that they had a working life expectancy 5 to 15 years less than somebody without depression. So now, moving from our study into context in real life, it's incredibly important to remember that reducing the number and severity of depressive episodes could increase working life expectancy for those who experience high depression symptoms, and this is where our policy and intervention efforts should be focused. Now, some potential policy and intervention places to start would be first to improve clinical and vocational supports to adults experiencing depression. The faster that we can get clinical supports to people experiencing depression, the higher likelihood that their depressive episode will be shorter and that they can get back to work. Secondly, it's important that we think about enforcing workplace practices to reduce the risk of depression symptoms that are attributable to work exposures. So we don't want our workplaces being risk places for developing depression. And lastly, we can increase access to healthcare and psychological therapy to minimize the severity of depressive episodes, to again, make sure our workforce is as mentally healthy as they can be and get them working and thriving at work. So with that, I'd like to thank you so much for your attention today. I'm really excited to answer some questions and happy to chat offline if you would like to about the study. Thank you very much.
Thank you so much, Dr. Dobson, for that wonderful presentation. There's a lot of really interesting insights, and I'm sure folks will have questions for you. I'm going to start off, and I think one question that folks are asking about is the idea that the data that was collected or you used was based in an American context. And you made mention to this. I'm wondering if you can maybe elaborate on the extent to which we can translate these findings into the Canadian context, or Ontario more specifically, where we're based.
That is a great question. So the answer to that is quite challenging, because obviously looking at the entire nation of America versus Ontario is quite different. We're quite different in our healthcare. We're quite different also in our labor laws. So one prime example is in the United States, not all women get a 12-month or 18-month maternity leave, but in Canada, we do. So given those differences, those known differences that we have, it's likely that our working life expectancies in Ontario may look similar if I was to hypothetically do the study, although they might not be fully exactly the same. However, when we go back to other literature looking at employment-related outcomes or labor-related outcomes between the United States and Canada, typically they follow the same trend. So to summarize that kind of wordy answer, they may look similar if we were to do the study in Ontario or in Canada, but there would likely be slight differences.
Great, thank you so much for that. Okay, so a number of questions and a lot of kudos to you, Dr. Dobson. So I just want to share that with you. First and foremost, I want to let folks know if you do have questions, please do type it into the Q&A, and we'll be trying to synthesize as many questions as we can and present them to Dr. Dobson. We have one question about the role education plays within the context of your findings, in particular the role of educational attainment. Would you say that educational attainment would be protective when it comes to working life expectancy, or is it too hard to tease this relationship apart given the sample size that you utilized?
So it's important to remember in this study, we used educational attainment, or highest level of education at age 30, as a descriptive variable. So we can't really causally say any information. However, when it comes to the role that education plays, not only in employment stability and employment experience, but its influence on employment outcomes when it comes to individuals with depression, we know that it's critically important. The higher education an individual has, the more stable their employment is, potentially increases the likelihood of having healthcare benefits related to employment. So if these individuals experience a depressive episode, they may have sick days that they can use, they can go on short-term disability, or have access to benefit packages where they can acquire medications and psychological therapy more easily. So it's definitely a critically important thing. And another perspective that we could take is if we think about the life course of an adult, really their educational attainment is what starts them in adulthood. Once they finished education, they then will enter the labor force and have different experiences. So it's kind of the idea, if we target individuals when they're still in education about their mental health and potential depression risk, then it's going to reap benefits for the remainder of their working life and for the labor force.
Great, thank you so much. So we have another question about the hypothesis you had as you started this study. And so I believe the first kind of landmark study on this topic was one that was based in Denmark. Is that correct?
Yes.
Okay, so the question that's being posed is, given the differences in support systems or social policy that exists when comparing Denmark to the USA, where the data was collected that you used in your study, were you expecting differences to be greater or smaller in your study? You've reported 5 to 15 years as being kind of like the key working life expectancy among your sample, which seems to be about the same as the Danish study. So I guess going into this, were you expecting something different than what you actually found?
That's a great question. And I think initially on the surface, we might have been expecting a larger difference, But there's a big big difference between our study and theirs. In their study, the group with depression either had a single episode or had a recurrent form of depression. They didn't discern between the two. In our study, we actually broke it down to say, we know that there's different courses of depression. Some people might just have it once, a very short episode, and the remainder of their life be depression-free. Other people might be episodic, bounce kind of up and down with their depression symptoms over time, and some people may be persistent. So when we unpacked our findings, we actually saw that the working life expectancy estimates for the persistently depressed group matched up the greatest with those findings from the Danish study. So it really goes to show that the course of depression matters and the severity of depression matters when it comes to working life expectancy.
Okay, thank you so much. Another question relates to one of your final slides, which talked about recommendations for practice. One of the things you talked about was the importance of getting folks access to clinical care. And one person who's attending today's speaker series is asking about the overall lack of clinical counselors that can help address some of the mental health concerns that you presented on today. And so I know this is not your kind of specific area of focus, which is like clinical care, but I'm wondering if you can maybe speak to this kind of gap in access to care and how it might play a role in your findings. What are some of the kind of insights you might have to share with regards to that?
Yeah, so first I will say I am not a clinical professional. I'm an epidemiologist. I work with numbers, but I'm a psychiatric epidemiologist. So my specialty is looking at how mental disorders impact different social determinants of health at the population level. So just wanted to put that disclaimer out there. So we can think about it in this way. If somebody is experiencing depression or any other mental health challenge, the easiest way to improve their health is to get help. So that can be clinical help from a clinical professional, it can be psychological therapy, it can be other forms of therapy. But the longer it takes from when our symptoms start to when we actually get help, likely the longer our episode will be. And also, the more severe an episode is, it can potentially be more challenging to get out of it. So again, having a bigger gap than we want between experiencing our symptoms and getting care, that can increase the length of an episode, which can potentially impact working life expectancy.
Got it. So pretty important to get access to care, and that definitely is an area that we need to think about moving forward, especially for those in that field of research and practice. Okay, so kind of in a similar vein, we have some folks who are asking about what workplaces can do to address some of the issues that you've raised in your presentation. So beyond kind of short-term and long-term disability or sick days, what are some workplace practices that you believe could be quite promising to kind of address the impact that depression or other mental health conditions might have on one's ability to stay employed and be productive at work?
Yeah, obviously incredibly important to talk about. So when we think about the workplace and places that we could put interventions or different policy, we obviously have the level of the worker, the level of the employer, and the level of the workplace. So definitely lots of places we can put different interventions. But one potentially easy one would be for different workplaces, obviously, is flexibility. So obviously stress can be an extremely big influence on our mental health and potentially depressive symptoms. So the ability to have a flexible work schedule, so you can see a psychologist or a social worker, or you can start work a little bit later if it's better with your sleep cycle. Again, a very simple thing if workplaces can manage it. Again, having access in benefit packages, if that is possible for your workplace, having benefit packages where we can access psychological services is really important. So when it comes to depression, the psychological gold standard of care is cognitive behavioral therapy. And for the care to be effective, the treatment has to range from 8 to 12 weeks. And in Canada, on average, an hour with a psychologist costs about $200. So obviously only having benefits for 1 or 2 sessions isn't going to cover somebody's entire course of treatment. So as much as we can get in our benefit packages, it definitely will pay dividends for workers.
Okay. So I'm going to probe you a little bit on this because we have some follow-up questions related to this one. And that is on the work environment. So obviously you've talked about things that employers can do, kind of interventions or policies or supports that are promising. But I guess one area of concern is the work environment and the role that plays in maybe exacerbating different mental health conditions. And I'm wondering if you can maybe comment on things that workplaces can do to potentially make their work environments more favorable to folks who might be living with a mental health condition. Is there ways to address the work environmental or psychosocial exposures that can either create a mental health condition or make it worse?
Definitely. So I'll give 2 examples of places in the work environment. The first is psychological demands. So how psychologically demanding do you find your work? Obviously, if somebody has lower mental health, which can potentially influence the onset of a depressive episode, having a really psychologically demanding workplace may not be the best, especially if they don't have a lot of decision latitude or ability to really have a say about how their work is done. So that could be one part of the work environment we can focus on. And a second one is the security of a job. So if somebody has poor mental health to begin with, again, which potentially is a risk factor for developing clinical depression, going to a job every day where you don't know if next week you'll still be employed, that's extremely stressful. And of course, not all organizations or workplaces can fully address that, but the idea of providing stability in employment when you can.
Okay, so it's a lot about the work arrangements and what that can mean for feeling of stress and the security that one has at work. So yeah, definitely important for mental health across the board. Okay, so we're going to change gears a bit and focus a little bit on the discourse that you presented with regards to race, and that was pretty prominent in your discussion. Obviously, the US does a good job of collecting race-based data and analyzing it, especially within its data sets. So it was kind of interesting to see that presented here. So I'm going to ask you kind of a two-part question. The first is among the racial disparities that you were able to kind of tease apart, can you maybe explain some of the mechanisms that might have helped to explain that? Like why were folks in the Black community potentially performing worse or having worse working life expectancies when compared to those in the non-Black or the white community?
So this is a really important question, and we could have a whole presentation on it, and probably should. But I will just highlight some of what the literature says. So in the demography literature of working life expectancy in Americans, it's typically shown that Black women compared to white women, their discrepancy in working life expectancy is smaller, but the discrepancy in working life expectancy between Black men and white men is quite large. And part of that is related to longstanding labor inequities in the American labor force. But another part of it is how Black communities versus white communities think about work. And there is a huge literature on that, and I really recommend people read into it, especially about the role of work in the lives of Black women. The other, in this area of literature, the other topic that comes up is the idea of social stratification. So different pressures preserving the hierarchies of different groups. And again, it's a really incredible literature. People should go read it. But a way that that may be playing out is in the Black community, they typically, based on the literature, access care later than white communities do. And part of this is fear of stigma, fear of losing resources, and in some cases, mistrust of the medical or clinical community. So because of that, again, the longer it is before somebody receives care, the longer somebody's episode will be. So obviously potentially impacting the ability to work, which may be why we're seeing these discrepancies in working life expectancy.
Okay, interesting. And yeah, I guess the number of structural factors that play a role in the working lives of different communities definitely is one that needs to be teased apart. And I realize this is not your area of expertise, Kathleen, but I think it's an important finding that maybe folks who are scholars in this area might want to think about as they move forward, because I think there's some compelling findings that require additional research to help explain why this is the case. So thank you for that. To follow up on that, one attendee is asking about other racial or ethnic groups. And so obviously, again, this might not show up in your data, but in contexts like Ontario, obviously we have a pretty diverse population. There's folks in the Asian community or South Asian community, and they also face different mental health challenges. So I'm wondering, like, is it possible to maybe draw some conclusions on other racial or ethnic groups that maybe folks in Ontario could think about as they move forward in research and practice on this topic?
Yeah, definitely a really important question. So in the National Longitudinal Survey of Youth data, the third group we talked about was non-Black, non-Hispanic. And among that group, about 85% reported that they were Caucasian, but the other 15% included individuals who were Asian, Southeast Asian, Pacific Islanders, as well as Native Americans. So it is possible with the data to start to look at these associations, but the challenge is, and always a big challenge, when we work with population level data, as we've seen in other parts of our findings, the more you stratify things down, the smaller your sample size is, and it limits your ability to actually see what the true association is. So I highly recommend, if people are interested, it's definitely an option to look at with this data set, and I'd be happy to collaborate or talk about on. But it definitely points to the need that we need this to be able to have this sort of data in Canada, so we can actually build evidence about what our population looks like.
Okay, thank you for that. One question that was posed was with regards to the working life expectancy graphs, and you kind of showed the declining trend across all the trajectory groups that you had identified. And one thing you had talked about is the fact that it might be attributed to retirement, and the fact that at older ages you are going to leave the labor market regardless of whether or not you have a health condition or not, and maybe having depression or any other mental health condition might kind of accelerate that decision. But I'm also wondering if there are other explanations that exist. For instance, disability or other financial difficulties that might make working more challenging. So, like, based on your research or other insights that you've kind of been exposed to, like, is it just about retirement, or might there be other issues at play here?
Definitely, and you bring up a great point, and I just want to go back and talk about one thing in our model. So your question also kind of points to the idea that we put a lot of assumptions into our model. So when we look at our 4 labor-related groups, we have employed, so these are individuals who are working. We have unemployed, individuals who aren't working, but are potentially interested in working. We have suboptimal labor force, which was really comprised of 2 groups. Either somebody, it wasn't really sure if they were employed or not, or if they had a health condition impacting their ability to work. And there were questions in the survey that asked about that, as well as we took a little bit of information about disability benefits to compose that group. Then our last group out of the labor force is kind of like a mixed bag. Across the working lifespan, people have lots of reasons for not being in the labor force. It could be retirement, it could be caretaking responsibilities, it could be physically not healthy enough to be able to work. So this was one of the assumptions that we put into the model, that this is kind of a mixed bag. So our models themselves won't actually tell us why people are leaving. But that's definitely something that we can look into the future. And yes, there could be lots of reasons related to disability, caretaking, retirement that somebody might leave the labor force for.
Yeah, I can imagine that just over time, if you're working with a mental health condition, it would just get tiring. And just this idea of having to self-manage at work, outside of work, probably takes a toll on many folks. And I guess that's one thing that struck me is like I just wonder if, in addition to being later in your working life and having that option to retire, it's just like this accumulation of feeling unwell over time that just makes someone make these hard decisions.
Yeah, definitely. And that's not just for mental disorders. It could also be for physical health conditions as well.
Yeah.
And I would also like to point out that the mental health labor literature shows differences between mental disorders as well. So here we focused on depression. However, some extremely severe mental disorders such as psychosis and schizophrenia, the amount of time people spend employed with those conditions is quite small. And there's fortunately vocational programs that have been trying to help those individuals get back into work, but definitely the severity of the condition is going to impact your working life expectancy.
Yeah. Okay. So kind of related to some of these slides, one participant asked about slide 22. So maybe you could flip to that if it's possible.
Yeah.
And the question is, why don't the low symptom groups cross other groups towards the end of someone's working life, as they've likely worked more, likely earned more, and over their working lives, maybe more able to retire earlier than the other groups?
So
So I guess like the question is like crossing
yeah,
over.
so that's a great question. And again, I think there's two parts of it. The first is, again, we go back to the model. This is what we modeled to be able to get our working life expectancy estimates. If we teased out these labor force states a little more in the model, we could potentially see a little bit of crossover. We didn't do that because we wanted to be as broad as possible and include as much information as we can. And also these models are extremely complex to run. They take a long time to run. So sometimes starting out simpler is better. But when we go back to these graphs, again, and we don't see too much crossover over time. The point estimates may have a little more crossover, particularly when we kind of get around to age 45. The confidence interval for the average working life expectancy, which we've plotted here, may have a little bit of overlap. But the important thing really to take away is that kind of between age 30 to 45, there's really clear distinctions between the persistent low symptom, the episodic before age 40, the two episodic kind of around age 40, age 50, and persistent high depression symptom groups, which is really showing that there's a clear gradient in working life expectancy at the beginning of someone's career based on depression symptoms.
Okay. Yeah, I think one of the compelling things about this presentation as well is it just raises a lot of future research questions and a lot of next steps, I think is kind of what I'm taking from the presentation, and a good foundation for future research and practice. And I guess that kind of leads to the next question, which is from one individual who's asking about next steps. Where do you plan to take this work? Like what do you feel like are the next critical research steps to kind of move this area of scholarship forward?
That's a great question, and whoever asked about it, I think about that every day. There's two avenues that we can go. So if we think about still working with this American data, now that we know what the working life expectancy is, we need to start asking, well, what are the factors that can change that? So, for example, in our modeling, we haven't modeled about whether somebody received psychological care, whether somebody received clinical care, the duration that they had spent at their specific workplace. So understanding not only what clinical related factors to depression, but as well as kind of healthcare policies and labor policies, what can potentially have the biggest bang for our buck for increasing the working life expectancies with those with depression. So that's one avenue. In Canada, I'm currently leading a project where we're looking at the employment trajectories of Canadians with multiple mental illnesses. So including depression, but again, we need to expand this area of literature to look at other mental disorders. So in the project I'm currently leading, we'll be looking at employment trajectories of those with depression and anxiety, bipolar disorder and schizophrenia, eating disorders, and substance use disorders. So stay tuned, perhaps that's a later speaker series presentation, a shameless plug there.
Well, Dr. Dobson, thank you so much for presenting today. I think many of us learned a lot, and I think it just definitely got us thinking more about future research and practice in this area. It's really important and understudied area, and I think you've definitely done a good job of kind of stimulating our brains. So thank you so much for presenting today. For folks on this Zoom webinar, I just wanted to highlight that we try to run an open speaker series on a monthly basis, and our next speaker series will be in January. We will invite you to sign up for our monthly e-newsletter, which will provide you with an opportunity to stay up to date and keep you posted on new speaker series presentations that we would love for you to attend. So again, Dr. Dobson, thank you so much for presenting today, and thank you to everyone for attending. And we look forward to seeing you in the future. Have a good afternoon.